Good afternoon. Yeah, I got a hair out of place. Put that thing back. How are you? Anthony, we can't hear your lovely voice.
You cannot hear my lovely
Now we
voice.
can. Yes, you were, as we enter into live anything, yeah, your speaker was off. How are you today?
Good, good. I was just doing the openers. I apologize about that. Just
No.
pardon me for 1 second. So, folks, thank you so much for tuning into the Marketplace Reset and Jumpstart Show. This is segment number 1 on health and wellness. I'm Anthony Weeks, executive producer and host, along with my other co-hosts for this segment, who are the hosts for segment number 1 on health and wellness, both Linda Dorman and Yvette Wood. They're both healthcare professionals in the respective area of administration and the clinical side of things. Ladies, how are you doing today?
I have no complaints. How about you, Yvette?
I'm doing well. A little warm. I was telling Anthony, I think it's 100 degrees over here right now, but I'm on the West Coast.
You're on the West Coast.
Yes, I'm in Nevada, and it's a little hot. That's
the desert, isn't it? That's the desert.
Can be, and mountains. Yes, I have a sister that lives there in Summerlin, so yes. Well, better you than us. It was hot this week, though. I mean, I had pool time, which is why, pool here. But yeah, we are getting a little bit of rain, I think, this afternoon, but it's overcast. So just travel safe, be safe.
Yes.
And Anthony, we always know that in St. Croix, it is perfect, except for when those storms breeze through. But
wait a minute. Wait. I don't. You're setting the bar too high now. Perfect. I know we are a place where people like to come to, but we are certainly far from perfect. Speaking of heat, a couple of days ago, I think it was Monday, it was sweltering. I mean, it was the heat was on, and so yeah, we do have our challenges as well in terms of the heat as well. So this is I'm glad you mentioned that, because on the next segment coming up, segment number 2 on business, economy, and public policy, we're going to take a look on we're going to do a presentation on the SBA small business preparedness for the hurricane season. And so we're going to provide some valuable information as to prepare businesses to be proactive on the issue of what to expect this hurricane season, and to make sure that folks are making the right set of plans and preparation to help mitigate any potential impact from this hurricane season. So thank you for helping me to share that piece of information as well. But ladies, COVID is I can't just say COVID. Delta.
The Delta variant.
What the heck are we making a 360 degrees turn on this thing? What's going on? What's happening here?
Alex, we're making a 380, Anthony. It's kind of come full circle and turning back the other way, because we've got COVID, we've got the Delta variant that everybody's talking about and you're hearing all over the news. But most recently, the Lambda variant has made its little ugly appearance with the cases here in the U.S.
The what? What did you just say?
The Lambda variant. It just keeps changing and it's getting worse. It's not
Lambda. It's the next alphabet. Well, it's one of the Greek letter alphabets. In other words, what you're hearing is we are actually progressing from Delta to Lambda. And it may not necessarily be a linear progression, but as we've had multiple mutations, this is another mutation.
But when I think of the word progress, I always put it in the context of something good happening. So when you use
Evolving,
the word, okay, thank you so much.
I stand corrected, and that's a good distinction. You're right. There is no progress in anything like this, except for hopefully where we have no numbers. No, but that's not true, and it's very daunting.
And this next thing is called is it part of the virus? Lambda? Is it part of is this another mutation of the virus?
Exactly. It's another mutation with worsening symptoms than before. We had the SARS-CoV-2 that came out. We had the alpha, the beta, the gamma, the delta, and the lambda. And each time we go down the alphabet, it's getting worse. It's not getting better.
So
you gotta be kidding me, ladies. What
we're not kidding. This is the thing. That's a very good point, because I do believe, because we started out in the U.S. with our fierce chief commander and president at the time saying it was a hoax. So therefore, people did consider it as, you're kidding. Literally, that stuck and stayed to the point where it has decimated and devastated. It has killed, hundreds of thousands, over 600,000. We haven't reached, I believe, the 700,000 mark, but it is getting closer and closer. Each one of those lives represents a family or an association where people cared, hopefully, about that person. Sometimes we've seen whole families, mother, father, son and daughter, daughter, son, father, just pass, entire families affected to the point that they're no longer here. So I can appreciate when you say, are you kidding? Because it's one of these stop and think, what is going on and why? How are we not in our public health care getting our arms so wrapped around it? Where our public health care is really a combination of not only the clinicians, the scientists, those providers, but we as general public, the citizens, the patients, the first responders of our own health. If we're not willing to do what Yvette had and her practice has taught others to do, what we have espoused and we have educated and we have implored people to please practice these safety tips, even those governmental agencies that you may or may not trust, just common sense, we're going to still be here. We're going to be all the way down to we're going to hit Omega. And then what's the last one in the alpha? Who knows? It's just going to be it's just really, and it's impacting our young people more. And we're seeing the rise in the young under 12 because they're not getting vaccinated. So, this is a conversation of pediatric care that we should actually add to our program for the listeners. So this is top of the line. This is breaking news. This is what the headlines are talking about right now.
Well, let me just share with you, and it is certainly not the kind of news. Okay, so you do understand there are two Virgin Islands. There is the U.S. Virgin Islands and there's the British Virgin Islands. Okay, so the U.S. Virgin Islands is comprised of St. Thomas, St. Croix, and St. John's, and some will say Water Island, but Water Island is part of St. Thomas, right? But for the purpose of you used to say Water Island, and then of course you have Tortola, Virgin Gorda, and the other British Virgin Islands. So they have a situation in the BVI where in less than 2 weeks, they've had 23 deaths.
Wow.
Deaths.
And you ready for this? Wait. Are you ready for this? The size of the BVI, the population of the BVI is 30,000 people.
Yeah. Combined.
So right. So put things in perspective, right? That the sheer size of the British Virgin Islands in totality, 30,000 people, right? Give and take. And they have literally saw 20, I think the number that I saw this morning on headlines, that they're now at total death for the past, I think it's 2 weeks span, is about 23 people have died from COVID.
And some would say that 23 is so low because they're looking at that in its virgin or raw state. Not per capita. But when you're looking at the per capita, that's the point we need to make, that the per capita, because those are the deaths. We know that for every death, there's XYZ factor for how many people are infected in the hospital, and XYZ factor for how many people are infectious, but are asymptomatic.
Right.
So this is why this has got to be a public health cry yet again.
So to put things in perspective, Brazil, which is having the worst outbreak of the virus, Brazil is about, I think, maybe 200 million people, give and take. Their numbers are at 44,000 deaths. I think 2 days ago, they reported nationwide throughout Brazil, 4,000 people have died per day. This is per day.
Yeah, I was going to say, yeah, not overall, but yes, because they have been they have suffered from alpha to current. It has never waned. And it has been one of the worst hit countries within this and outside of China. It has just been in India.
So we got work to do. We have work to do.
Lots of work to do.
We have work to do. We have to really really prepare ourselves to really start to provide the level of education and information to allow people to be equipped so they can understand how best to be able to, manage this environment.
Well, you're stuck, Anthony, but when he talks about education, Yvette, you're an educator, I'm an educator. We have an educator on our show today to talk about exactly how this next generation of healthcare providers will in fact take up the banner and carry this ball all the way to the end of the field, and hopefully develop and be very much a part of the innovation that's going to get ahead of these potential pandemic epidemics, and come up and look at it from a research perspective. However COVID showed up in our global community outside of Wuhan is up for continual debate for probably the next 100 years until perhaps the next pandemic. But it is what it is. So I don't know if we can get our guest on at the moment, but I do want to go ahead and at least introduce him. And hopefully Darren is in our backstage because he's a phenomenal guest. We always have phenomenal guests. I mean, everyone is so content rich. And Darren Gilstrap is the founder and managing director for Inner-City MD, a diversified digital health content, media technology advertising agency is his gig, his big gig. And then he has an even bigger gig. He has multiples. And this connects just a variety of important health content to the user to actually utilize and move forward in their lives. Because remember, we talked about the fact that you had to be your first health responder, your medical researcher, so that you're smart, but you're not self-diagnosing. You're using that information in conjunction with your healthcare providers to be a smart patient. And that's what we have to do. Let me just read a little bit more. Inner-City MD is the culmination of Darren's 35 years in the medical academia field, critical, clinical, bedside technology, and biopharma. Darren recognized early on the disparities in clinical health information technology not reaching underserved physicians. And that's an interesting category, underserved physicians, hospitals, and their patients simply based on community demographic and zip codes. And Yvette, I think that we've almost, lost our eyeballs talking about this, lost our mouths talking about the health disparities among communities of colors that include not only the patients, but the health providers and the resources therefore available to them with state, federal, and local funding, as well as insurance support for those individuals who are underinsured or not insured at all, even with the Obamacare, I'm going to use it as Obamacare because that was my favorite president. In any case, Darren comes to us today in a conversation around training the next generation of healthcare providers, and really looking at the medical education field overall, because we have to understand where is this knowledge being transferred, and then how are we raising up the next generation of healthcare workers. He is adjunct professor at several locations, but today representing the State University of New York. And I'm really excited to be able to welcome him to the program, and hopefully he can get on. And what do you think about that, Yvette?
I think this is great. And Linda, if you go back to some of our previous conversations, like the first one when we were talking about COVID and how the medical staffs were just not prepared to handle that, and how they didn't have enough knowledge on really what COVID was. So for him to come now at this time where we're starting to see the numbers spike, to talk about how he's preparing our, healthcare workers for this second round, third round, fourth, fifth round of pandemic, however many it takes to get this eradicated, I think is great. And I think it's timely. I'm very interested in to see how he is preparing the healthcare force for this new pandemic. In addition to the healthcare disparities among physicians, that's something that people really did not pay much attention to, the fact that every physician was not able to put their hands around the vaccine. They're not able to get the same medical supplies that some of the other physicians, so they cannot care for the population that they care for. I had the pleasure of working with one of those physicians down in DC in Medical Reserve. He was swabbing people because he couldn't get what he needed to treat patients in his practice. He would even go home to home. He was doing house visits during the pandemic to make sure that his clients got service because they were of the lower socioeconomic level and they were not able to get out to get healthcare. So I am so excited for today's guest to join us, because I'm sure he's going to be a wealth of information on both of those topics, which I hope very near and dear to me, because we absolutely must eradicate this virus. And
I love everything you're saying. I'm not trying to interrupt a syllable. I just wanted to let you and the audience know that we do have Darren in our back room, and as live anything goes in the broadcast world, we do have a little bit of technical issues, and we'll hopefully bring him in and look forward to that conversation. We ask him to hang tight if he can hear my voice, but you did mention something, Yvette, as it relates to being near and dear, and that's true. One of the things that you and I both know as African-American women, there's been a lot of discussion around health disparities in the provision of services for women of color. You walk into a hospital, whether you're pregnant or you have surgery or you are being seen by your provider, there's been this global concern. Am I going to be believed? That my health problem and the pain that I'm experiencing, my intuition around the fact that I feel not well and something is happening and I need expert care, sometimes is not there. There's just degrees of different health disparities that we have to address within the healthcare system in order to be vibrant and viable and certainly accessible to all. I know you've probably experienced some of that in many of the healthcare systems that you've worked in. You just gave us a great example of that.
Absolutely. And it's unfortunate that it still exists today in 2021, that we even have to have this conversation. We would think by now we would get equal health care for all. But unfortunately, that is just not the case. And we need people like our guests to lead us to that point where we can get there, so that people are not on this broadcast saying, I can't get the health care that I need or the health care that I deserve. I can't get the supplies to take care of my patients. I can't get a hold of the vaccine. And as we were discussing earlier with Anthony about Brazil's another place that it's disparity. They can't get the vaccine fast enough or enough of it to treat their people. But we're here in the United States. We have more than our share, and we can't get our people to go and take the vaccine. I was walking down the street out here in Nevada, and there's a place that said, please come in and get your vaccine. Ghost. No one was walking in those doors to get this vaccine. And it's unbelievable when you consistently hear the news about how the virus is mutating and evolving, and it's not doing that for the good. So, I agree. And then we get into the cost of disparities and the money and the utilization and where it's going, where one hospital can pave their parking lot and another one just needs money to pay its employees, which are needed to provide health care for the patients.
And I worked in a healthcare system that had to make those very tough decisions, quite frankly. And I look forward to our guest next week, who's going to be coming from that healthcare system, talking about women's health in particular and the disparities there and the kinds of things that this hospital system is doing to bring about change. I think one of the things that has struck me, and Mr. Gilstrap, when he gets online, and I have had some interesting conversations around, is the landscape of healthcare. We used to have our community hospitals. And so you had your community resources that was wrapped around everyone knew everyone. or everyone had a sense of ownership of that local healthcare system. Now today, we're seeing this ongoing, strategy around conglomerates, where healthcare systems, for the very reason you just talked about, resource deprived, are now coming under corporations, and those corporations are driving policy, healthcare policy. These healthcare management companies who are now becoming the conglomerates of, or even academia, medical system that is really an offshoot from a university system that has a medical school and maybe therefore adjoining hospitals where they can bring those students into practice. I'm not sure how that's playing out at the local community level. What is in your travels, because you do a lot of traveling in the round of medical fields in different states, what are you seeing out there?
What I'm seeing, Linda, with how that's playing out is it's affecting the patient. That's the bottom line here, because we're looking at bringing people in, especially during the pandemic. I'm sure you may have heard that some of the doctors and nurses were allowed to complete their education sooner, kind of shortcut some of the needed education just to get them in the field because we did not have enough healthcare workers. And on top of that, then the bottom line was some of the patients suffered, and we have our guests, and I'm so excited to see you. So I will stop talking because people want to hear what you have to say, Darren.
You guys are well more learned than I am. So
well, don't get us started, because Yvette and I will, next thing we'll know, we'll be picking up our water bottles and start really going at it and forgetting that we're supposed to have a great conversation with you, because the passion is there, and we know the passion is there for you. So welcome, Darren Gilstrap, to the program Restart, and we are so glad that our technical issues, we've got a good amount of time, and we look forward to having that dialogue with you.
Sure.
So let's just hop into it.
Sure. You guys sort of splattered the field with some great topics, and
yes.
And actually, I think all of our communities are very passionate about not just healthcare disparities, but financial disparities, housing disparities. As they say, COVID kind of unscathed or unscabbed a lot of the disparities in our communities across the board. So I shouldn't say that I'm happy that it happened, but I'm saying I'm happy that it's now more relevant today, whereby we can address these issues from our different subject matter experts, whether it be healthcare, like you guys and myself, or the financial services folks, or the educational folks, which kind of comes into our conversation here as well, or transportation folks. I mean, it's just, pandemics have a way of really, pandemics are like the drunk at your own family gathering. They say stuff that you don't want to be said, but people's like, well, it's true. It's true. Uncle Joe, shut up, Uncle Joe. But anyway, get to the seriousness. So.
But that's true, though, Darren. You're right. Yeah. And sometimes, isn't it true, though, when we get together as family or in groups of familiar individuals, we start to try to solve the world's problems.
Right.
And we begin to have a cross mix of a lot of different opinions that then become, in some respects, our facts. Right. And this is where the danger, that's a beautiful exchange. And we think it's healthy because that's what builds community love and understanding among people. But when we start to bring in an opinion that becomes facts based on people's perceptions, particularly around, getting vaccinated.
Right.
This becomes the danger, because then it becomes one person's experience that may not have been as great. Perhaps they got sick, but everyone else who received a vaccine did not get sick. But that one person becomes the next driver of opinions on whether or not I'm going to or I'm not going to. So we've got to figure out a way to use that voice, that family and familiar, the familiar voice, I should say, advocating the benefits that we're seeing in this pandemic. And that's what we are espousing to do, is to give them enough information to take that voice back into their families, their communities, their friendship circles.
Right.
And let's get this done.
And as we all have heard over the last, it's been like 18 months, because I remember we went virtual academic wise. I was in Pennsylvania teaching one of my academic positions, academia doesn't pay, so you got to put together like 4 or 5 positions
Yes.
just to make the ends meet. But so I was teaching physiology and a few other courses in northeastern Pennsylvania, and I was driving from Manhattan to Pennsylvania literally 5 o'clock in the morning every day to catch my 8 o'clock class, and then I would turn around and come back home at 6 p.m., be home by like 7:30, 8 o'clock, and then do it all over again the very next day. And the pandemic actually hit the university at around March 10th, right around spring break, which was kind of good because I'm like, oh, gee whiz, he's got spring break coming up now. But what happened at spring break was they said no one is coming back to school. Campus is officially closed. As a matter of fact, you can't even not come in and you can't clean your office out. So they said teachers, faculty, all leave your stuff at your desk. You know, janitors will come in and bag it up. You'll get a chance to come in June, July to clean your desk out. So I didn't get a chance to clean my desk. Literally, I left everything as it was because I was coming back from spring break and just resume my day. But I didn't get a chance to come back to my class in my lab until like July. And I had to prove to the student health services that I already had like 4 or 5 COVID tests. And actually, interesting enough about COVID testing at the time, I had been talking to a few biotech companies, and I had access to the rapid antibody test that you can prick your finger. And I was doing pricking my finger daily, if not every couple of days, looking at, do I have IgM antibodies, IgG antibodies? Of course, I was asymptomatic, but that was one of the disparities in information technology that our practitioners did not get, because we talked about practitioners being subject to health disparities, but also our communities. So think back to May, June, and July. No one knew, first of all, where to get a hold of an antibody test kit. No one knew what the rapid PCR was. No one knew what an antigen test was. Do I spit? Do I swab my tongue? Do I get double nose, single nose? Do I go back in my throat? Do I do a blood test? And I remember actually having very, very forthright conversations and clinical conversations with my inner city practitioner community physicians. And we were really going through what we knew from medical school, what we learned about immunology, what we learned about epidemiology and clinical biostatistics. And, you know, we had students who were going to college at the time, who were just graduating from high school, planning to go to college. And the parents are like, okay, what test do I give my kid before they go away to college? But we also knew that kids weren't going back to college. They didn't realize that. So to sort of rewind, I was able to prove to my university at the time that I already had 4, 5, 6, COVID antibody tests, and that I was negative. And so I was able to sneak into school, and I sneak into school, like get escorted into school.
Oh, you were sneaking into school, all right.
yeah. I was sneaking, but I had, security let me in, and the dean let me in, and the nurse checked my temperature, which is another farce, because your body temperature can change if you're walking fast, Yes. So that's another whole sort of diagnostic pile of boo-boo. But anyway, so I was able to fetch my stuff out of my lab in my office and come back to New York City. And then we've been teaching online literally since March of 2020, all the way through to September. And actually, they canceled all the courses during the summertime. All the online courses they actually canceled. Canceled.
Darren, can you tell us a little bit about the types of courses? Because I think, for those who are not in the medical field,
right?
We can take all kind of amazing courses, and it seems almost normal online.
Sure.
But the challenges and hurdles you've had to surmount are pretty significant in medical education that
Sure.
all of a sudden had to go online. What types
Sure.
of courses?
So to give you guys a sort of 30,000 foot level, whether you want to become a nurse, a EMT, a physician assistant, nurse practitioner, medical doctor, most students take the core basic science classes, and those are anatomy, physiology, microbiology, maybe a general chemistry, organic chemistry, a biochemistry, and then do some sort of clinical practicum at some hospital at some point. And that's pretty much even at your community college level, it's still the same coursework. So whether you go to Baruch or whether you go to CUNY or whether you go to BMCC, you got to take the anatomy and physiology courses and the all the basic courses about how your body works, right?
Yes.
And then you spend some time doing your practicums over a year, 2-year basis. So so this is interesting. It's for some students, it was very hard to make that transition from being in the classroom to being online on a Zoom. And, a lot of that has to do with, we all learn differently. Some students learn differently. Personally, since my early days of graduate medical school way back in the late 80s, I was a fanatic of video-based education. That was how I like to learn, or not even video-based. I like to back in the day, learn medicine and science through audio-visual mechanisms. For example, I had cassette tapes, and I still have a couple of cassette tapes in my closet about how the heart works on physiology and heart failure. And I still have that cassette tape, 120-minute cassette tape from like 1982. I can't play it on anything, but.
And you're dating yourself, but I'm sure that Yvette can, this is walking her down memory lane, probably having sat in many of those classes at a university somewhere as a registered nurse. You think of medicine and medical education as being so touch and feel. Right. You kind of think of all the, Marcus Welby, MD, and of course I'm now really super dating myself. I was just a little girl with that. And then, just how that transition has occurred and what are some of the impacts? That's what what do you think, Yvette? I know that you've got, are you having like memory lane mode right now, having sat in some of these types of classes?
Oh, absolutely, Lyndon. If you remember, I'm still sitting in those classes.
I'm pursuing too.
My higher degree at the University of Texas, and I'm looking at this A&P textbook going, oh my God, he's taking me back. But they're needed classes in order to, and I'm sure Darren can attest to it. You have to go there to understand how the body works and how all this affects the body. Even the part that we're not directly talking about health. Let's talk about stress of the pandemic, how that directly affected the body and the students and the faculty as well, because the faculty was pressed to get education into the students so that they could graduate, so we could get them out there to help in the pandemic.
Right.
So it kind of just came full circle. Wouldn't you agree, Darren? Right.
And actually, I had faculty members who were really pushing against the online transition because, as you know, a lot of our faculty are hands-on faculty. They've been trained in the classroom for decades, and their transition, their sort of uncomfortableness with technology really showed itself. Fortunately, we had a president. This is at Northampton Community College. We had a president who was very sort of understanding and empathetic of the different types of learners we had. And those learners are both students and faculty.
Yes.
And because we were actually trying out the Oculus Rift for actually, this is prior to COVID, the semester before, we were trying out Oculus Rifts for anatomy visualization. So, which is actually kind of not superstitious, but kind of serendipitous. But to go back to your question, there were students who had trouble making the transition. There were faculty who had trouble making the transition. And of course, remember, some students schedule their classes around their daytime jobs. So here's the situation where they schedule their classes around their daytime jobs, plus their parents, they have infants and things like that. So now you have the situation where I have to go home and try to go online and do my lessons. And now my kid can't go to kindergarten or nursery school because the nursery school was at the community college. And, so it became a big cluster of social determinants of education, social determinants of health, social determinants of childcare, transportation, the whole nine. So there was no one that was not affected from this tsunami of a pandemic. To go to your question about where medical training is going today, there are more schools now that are more universities, both community, four-year colleges, and university-based schools, which I teach at right now online through Zoom. There are more and more schools that are recognizing we have to be ready for any and all contingencies. And it's not just pandemics. You're looking at floods, you're looking at hurricanes, you're looking at tornadoes, you're looking at forest fires in the West Coast, in Oregon and Washington State and California. How do you shut down your school but still keep your students on some sort of schedule where they can continue doing their pre-meds, their board exams, their clinical rounds. I'm not going to hog the conversation, but to give you an idea, down in Atlanta, and this is most of the medical schools, most of the residencies were scheduled to start July 1st of last year. Every year we get a new cadre of medical students coming out of medical school, going into the clinical for internship years. Well, that was all canceled last year because some of the students got to graduate earlier. But even the attending and the faculty had no assignments because everyone was on full deck in the ER. Everyone was on full call deck in the ICUs. There was no dermatology rotations. There was no ophthalmology rotations. There were none of those eccentric. Well, I matched dermatology and I matched plastic surgery. All that stuff went out the window. Everybody who had a degree and a tassel going over their head was put into the ER, was put into the ICU.
Oh my goodness.
Was on full deck. And so medical school and nursing school stopped as we knew it. It literally stopped. Everyone got drafted into the ICUs with 4 masks on, face shields, double gowned, the whole 9 yards. Until this day, the system has not recovered yet.
So if are we at the break, Anthony? Because I have a question regarding that.
Yeah, we are. I was kind of just indulging our guests because of the technical issues and the late start that we had. But I just need to do a station ID and just let the conversation continue. Folks, again, this is the Marketplace Reset and Jumpstart show. This is segment number 1 on health and wellness, broadcasting on WSDX. We're now officially WSDX Bloomberg Caribbean. We're also broadcasting on Tempo Network Television throughout the U.S., United States, and Caribbean, and in South America, Guyana, and Suriname. We're also broadcasting on our Hispanic station, La Mega Mundial. And we're also broadcasting across the spectrum in terms of online and social media platform. And certainly this is also powered by the Kalaloo Network. And so I want to just say, just for your edification, my colleagues, that my prayers and hopes for the people of the British Virgin Islands, because when we broadcast, our broadcast is not just heard in the U.S. Virgin Islands from a terrestrial radio standpoint, but also the folks in the British Virgin Islands can hear our broadcast in Puerto Rico and parts of the other immediate neighboring Caribbean islands from a terrestrial radio. So I would be remiss if I didn't say my thoughts and prayers and hopes with the people of the British Virgin Islands in what they're going through. And we are going to do our part. We're going to do our best to try to bring all of the, if you will, the authorities and the experts to be able to have this discussion in real time, so you have the benefit of that. And so I want to be able to just say thank you to our guests on the program today, Daryl, and of course Linda and Yvette.
Yeah, well, we're glad to be here because we think this is such an important program to all the many millions of listeners and the viewers that plug in and tune in and have come to this platform for the past year in particular to hear some interesting dialogue. We try not to have it so structured that it's difficult to understand, but really have subject matter experts like Darren to come and give us a great perspective on what's happening out there in the healthcare landscape that matters to each of us in our families. And I think what's so interesting is when we think about the process, the chain, I love the chain of efficacy, the process of getting our students educated, our next generation of healthcare workers, whether they be doctors, nurses, technicians, physician assistants, respiratory, other professionals, clinical professionals, providing this measure of support, which strikes me in what you just said, because I've worked with medical students in funding those programs at the hospital system that I worked in the state of Maryland. And what I don't think that people understand is that you leave medical school, then you get matched. Mm-hmm. It's a lottery process in which you were so excited. So if you think of Grey's Anatomy, the television program, and they got matched in that very first, and they were so excited that they got in to this prestigious university, you then move into that in-hospital clinical practicum or experience. And that gives you, and then you become an intern, you work with a resident and move into and progress in your career and your specialty perhaps. What I'm hearing you say, which is news to me, is that we bottomed out. We just took that whole process out from the entire medical education chain, and we moved from medical school graduation to I will see you reporting in the ER department tomorrow. That is, you both are clinical. I'm management. So walk me through the significance of that.
I mean, maybe Yvette may want to start on that.
I have a burning question for you, Darren, because what I have found was without that hands-on experience in the clinical practicums, the nurses that I was getting to train did not have what they needed to be successful. I had to teach them things like how to draw blood, how to start an IV. Basic nursing one-on-one was skipped over to push them through so we could get them on the floor. So you had to basically, start them over again. They got the education from the books, but they didn't have the hands-on education that I got when I went through school. I mean, the A&P classes where I actually bought a cat home and had to isolate all the muscle groups. And so I knew what the muscles were. It's all online now. So I'm like, how good of an education is that really when it comes to when they put a body in front of you? Because you're going to go, oh, wait a minute. Well, I was looking online and I think that's the deltoid over there, where I actually had to find a deltoid for myself. So I knew where it was. So I'm a little concerned about that, Darren, and I really want to know your thoughts on that.
Can we clarify? Can I just make sure I'm clear?
Sure.
Are we talking about this transition because of COVID specifically? Or are we talking about this is how the future of how medical students will learn the practicum, that they will no longer be matched?
Well, Yvette actually did uncovered an untold truth. And that's why adjunct professors like me, I never wish I'd be as an associate professor, but that's why professors like me are very critical to the pre-health professions educational platform. Because I'm actually known, they call me Professor G, but I'm actually known as one of the best professors they've had because I can take clinical and make it as very relevant to the basic science years as possible, because I've had 30 years. So I can tell you about the anatomy of a deltoid muscle and tell you 45 different things about it, why you need to know it as an EKG technician, because if you put the EKG lead over the deltoid, you get artifact. Well, I need to tell, if you're an X-ray radiography technician, I can tell you where to find it on the X-ray. If you are a sports medicine physiology major, I can tell you why the deltoid is important for mobility and rotation. So I'm able to sort of give this student, like Yvette, 1,000 different reasons why you need to know about the deltoid, right? Even if you're an ultrasound technician, you should know about the deltoid in case you have to do a glenophosphal. If you're working with an orthopedic surgeon, he's going to put a needle in the shoulder joint here, and you as the ultrasound technician have to put the ultrasound over the shoulder to help guide what we call needle-guided ultrasound. And so there's 1,000 reasons why you don't have to be the MD student or the nursing student. You could be an ultrasound student, radiologist, surgical student, and I would tell you why that anatomy lesson is really, really important to you. But to go to sort of our question, that what students got last year was what we call trial by fire. It was literally like, hey, yeah, you're a dermatology resident, but guess what? We ain't doing dermatology for the next 18, 24 months. Your goal is to go in the ICU, put on the mask, and start pumping on that chest. Learn how to put a intubation tube in, because even though you're not a respiratory therapist, you're going to have to learn how to intubate somebody. Okay, so
to help them breathe. For those who don't know that,
help them breathe. Yes, right. So the artificial airway they put down your throat. You're going to have to learn about we call a bag valve mask, which you may have seen on like ER or something like that. But you're going to have to learn about different nebulizers. So we all became crash doctors in pulmonary respiratory medicine, right? In ICU and critical care medicine. And, some of the students who are kind of sheepish, who come from, let's say, there's some people in New York, but I'm just saying people who, students who come from rural parts of the country or, lesser urban areas, they're not used to being thrown into the fire right away. And remember, you're on there from 10 a.m., you're on from 10 to 10 or 6 a.m. to 6 p.m. There was no breaks. Remember, you saw a lot of nurses and doctors sitting on the floor saying, I haven't had a potty break in 10 hours. Or, I have indigestion because I haven't had a chance to eat or sleep and my clothes are soaking wet underneath. So a lot of that was just it was like we were at DEFCON 4. I think DEFCON 4 is the worst. But that was medical school 2020 throughout the whole entire year until this thing sort of died out a little bit. And then going forward now, we're now looking at, okay, I can't be back in school until everyone is vaccinated in the hospital. And remember, your hospital staff is actually a composite of your local community, right? The local nurses, the people who are the ancillary staff, they still have their own sort of hiccups around why they should get vaccinated. And since we can't mandate vaccination for employees in most cases, you really can't safely open up a medical school or a hospital to the public until everybody on staff is vaccinated. And remember, if you were expecting to deliver a baby last year, your spouse couldn't come in and watch you deliver a baby.
Right.
How traumatic is that for an expected parents, or things like that. Again, on the medical education side, with so many people passing away so rapidly, there were no more cadavers to be had, because normally we get cadavers from medical training from people who donate their bodies in healthy times. And we had to literally funeralize people or cremate people because you cannot have a cadaver full of COVID as the medical school cadaver.
Wow.
So every school lost the ability to accept donations for cadavers from funeral homes and things like that. So that was a big upset in the first 2 years of medical school and nursing school. You had no cadavers for training on.
And no one would even have thought about just how that's so fascinating, because this is what we need in order to really train a generation or a class of highly skilled medical personnel. And that's what we want. We want highly skilled medical personnel. Right.
And most of your advanced fellows in, let's say, orthopedics, for example, right? They will take a pro section of, let's say, someone's shoulder, a cadaver shoulder, and they'll practice on doing rotator cuff surgeries on a cadaver pro section. But since there are no more shoulders to be had, they couldn't do it. Pelvic surgery physicians would take a pelvic, it's like going to a butcher shop, say butcher shop, but you take a pelvis pro section and you practice, fibroid lumpectomies, for example. None of those things could be done.
So when we talked about the lack of mandates and then now we have to think, now that they couldn't be done and we've got some, the system won't catch up to itself, all those kinds of details that are really critical to a comprehensive medical education will take some years to level back out. I think now the conversation becomes, how do we incorporate technology in replace of? Mm-hmm. So we do the electronic surgeries, if there's such a thing. Mm-hmm. And then, what should we do as lay individuals to support the mandates around getting vaccinated? Because I know out of Texas, there's the lawsuit stood for the healthcare system that mandated that, in fact, their workers did need to have a vaccination. So now we've got a precedent in the court system.
Right, and I think Indiana, the federal judge in Indiana, just yesterday or 2 days ago, said students who go to Indiana University must be vaccinated before they go on campus. Mm-hmm. So there are because this is a matter of public health. It's not a matter of the government forcing me to have something injected into me. Actually, the lawsuit was about how do you can't force somebody to take medical treatment against their will. But when it becomes a situation of public health, there are exigent circumstances where you can mandate someone take a vaccine or any kind of other medical therapeutic. It's almost the same way if you look at it. If I'm a patient of a psychiatrist and I tell you I'm going to harm myself or the public, and I'm an airplane pilot, that physician has a duty, a federal legal duty, to alert the authorities that, hey, I'm a danger to my passengers. So there are circumstances where you think that HIPAA and personal privacy and personal freedoms get tranched upon, but they really don't. It's really in the interest of public safety and public health that we can actually have these loopholes in a sense. Yes.
Yeah. I have a question but comment at the same time. Linda, are you getting feedback? Are you saying that? Because you sent me a
Yeah, it
text.
stopped. You're
It's
good
clear.
now. Thank you.
Yeah. Okay. So what the dynamic we have right now on this program, okay? We have Linda, who comes from an administration point of view. You have both Yvette and Daryl are both, if you will, practitioner on the clinical side. But Daryl, you bring in the education component of this. When you bring because we're talking about care now, this is the care side of health and medicine, right? Am I correct? Am I?
Yeah. It's a continuum. 'Cause remember, medicine is set up as a teaching. Medicine is teach one, show one, do one, or do one, see one, teach one. Yeah.
So would we agree or disagree that prior to the pandemic, we're in the pandemic, but coming out post-pandemic, that the pandemic has or will transform the delivery of care in terms of how the general public, myself, and those who are watching and viewing, that are we going to see a different type of care because of the pandemic?
Absolutely. And remember, even though we're all professionals in our given domains, at the end of the day, I'm still a father, right? And I take care of my 17-year-old child. I take care of my 81-year-old mother, and I have to take care of myself as well. So I'm still a consumer of healthcare, no matter how many numbers and levels I have behind my name. And to get to your question, I think I've seen my primary care doctor one time in person in the last 14 and a half months. We've had 4 telehealth visits on the phone. As a matter of fact, in the first 2 or 3 visits, it was just telephonic telehealth calls. Then the system was able to sort of get all their broadband together, and now those calls became telemedicine video calls. So you saw this trend. I've seen personally this transition from, and actually my doctor was remote in his apartment in Jersey, across the state, across the bridge. So they even had doctors not even in the clinics. So they would log in like a 3-party, like we're doing right now, a 3-party call into the telephone board at the clinic, and then the clinic would call me and say, "Hey, stand by for your doctor. He's coming on the line in 5 minutes." And I would have a 15-minute call, actually 5-minute call with my doctor, saying, "Hey, how are you feeling? No cough, cold, flu, no soreness, no adenoids, throat pains." And he was actually trying to screen me for COVID symptoms on the phone, which was like, wow, look, and he has to do this 25 times a day or 25 times a minute, an hour. So yes, today's consumer, you, I, all of us are brown skinned, particularly our community. We have to be extremely flexible and personally responsible to understand how the technology works. We've all had smartphones for 15, 20 years at least, give or take. I'm not sure what the status of smartphones are in the Afro-Caribbean diaspora, but I think everyone has. I've seen Facebooks where people in the Caribbean are on smartphones doing Facebook and YouTube and TikTok. So we have to sort of change our paradigm and say, hey, this little small handheld computer thing in my hand is not just for entertainment purposes. It can actually save my life or save my family's life. And I think we have to be extremely open to sourcing credible, timely, and culturally responsible or culturally targeted information that can save the life of a loved one or your own person. I mean, you mentioned in your opening about the uptick in COVID cases and COVID deaths in the Virgin Island territories. That's very, very unfortunate because a lot of it has to do with lack of information about what are your risk factors. There's lack of PPEs down there. But then again, remember, people are still transporting themselves or traveling in and out of these countries with little regard for personal and public safety. I know that I've been, we've all tried to go to weddings in Jamaica or weddings in other countries, and they're like, you come down here, you have to test 2 days before you leave the USA. You got to test when you get off the airplane, and you have to be quarantined with the local authorities for the entire vacation that you're down there, and you can't leave the all-inclusive location you're going to be at and travel the countryside because of COVID. So, but to go back to the way we're getting healthcare today, I'm actually yes.
My apologies.
Yeah.
We the clock we've ran out of time.
Sure.
And so what I'd like to do, if possible, if you can coordinate with my colleagues to have a sequel, a follow-up in a discussion with you, because what you are sharing is very insightful, and enlightening, and I'm sure our audience would really appreciate having you back.
Well, that's another thing about the technology. There's so much information to get out there to empower our communities, and that's what I hope to do as a medical educator, as a digital health media practitioner. Is we use these technologies that literally, I mean, this could be a 10-day telethon of information, and it still wouldn't be enough. Right. So I appreciate you having this platform here to get some of that information out there, because it's never going to end. Remember, our brain is designed to be empowered with information. Information makes our families stronger. So thank you, everybody, for that invite.
You're very welcome. Thank you, Darren.
You're welcome. I think what we can share with the listening public, viewing public, we're so serious about this whole healthcare space, medical space, in terms of we're not just having conversation, we're actively in the incubator, if you will. We're in the laboratory, if you will, from a figurative sense, from a literal sense. And you heard Linda mentioned earlier, she used a term called chain of efficacy, or the efficacy chain. That is a proprietary, if you will, process or system we've created. And so look forward to the future when we talk about the transformation of this healthcare space. And when you hear the chain of efficacy or the efficacy chain, know that we are the people working diligently to be able to bring about a different approach, a different application as to how people understand and see the delivery of healthcare and going forward in the future. So I want to thank you for that.
Absolutely.
Linda and Yvette, unfortunately, time flies when you're having fun, but you're getting a whole education on this process.
I completely lost myself in this conversation, I must admit, and that's why I wasn't as talkative, because I've been trying to write my notes, not be rude and looking down, but thank you so much, Darren Gilstrap. I appreciate it, and always
thank you.
Yvette Wood and Anthony Weeks, you're the best.
Thank you so much, ladies.
Yes.
Thank you, Daryl.
Thank you.
Okay, until next time, folks, this has been another edition of the segment 1 on health and wellness. This is Marketplace Reset and Jumpstart. We'll talk next week.
Thank you.
Bye.